Hello, everybody. I'm really looking forward to speaking with you today about addiction and stigma, what you need to know. So allow me to introduce myself. My name is Dr. Conrad Sichler. I'm a family doc, but I mostly do addiction medicine. I use GP psychotherapy. And in the last 5 years or so, I've done more in terms of the treatment of psychological, emotional, mental trauma. I am the person in Hamilton who healthcare providers with addictions go to. Not the only person, but one person. I facilitate a group therapy for them when they're on their recovery journeys, and I do other things besides. So I want to start us off with a case study of a 21-year-old male who presents to the emergency department with suicidal ideation and a suicide attempt that night with about a 7-week history of depression. He was transported by ambulance, physically well upon arrival, didn't need any sort of medical intervention. He had some low mood around a breakup. The physician contracted for safety with him. His parents were called, they were able to pick him up, and he was sent home, but there was no follow-up. So I'm going to return to the end, just keep that one in mind. I'm sorry, have we met?
I don't believe we have met before.
No, when I was growing up, it was pretty lonely and weird. Like, my parents were Czech immigrants, and there was a lot of paranoia in the house. I read a novel later, Fugitive Pieces by Anne Michaels, and it sort of described the house I grew up in perfectly. I almost dropped the book. There's a paranoia that communism would come and somehow take over. I was an only child, so there wasn't really anyone to talk to about it. The attitudes were really quite patriarchal. My dad would boss around my mother and me, and he'd give us the silent treatment when we didn't really do what he wanted. So let's talk about stigma. There was a Canadian study that's posted on the CAMH website that shares that 46% of Canadians thought that people use the term mental illness as an excuse for bad behavior. I found that quite astonishing, and I asked, what does that show us about ourselves as individuals and as citizens in a collective in Canada? What does that say about our psyches and our understandings? And I think the conclusion that I came to is that there's a lot of blame and judgment. I did look for studies to see if there was any support for my gut feeling that addiction is kind of like the most stigmatized of all the mental emotional disorders. And there was one that I found from 2013 in the States, an online survey of about 700 people, where it showed that Americans overwhelmingly hold the worst attitudes towards people with addictions versus other mental health issues, including not wanting them around in their family, not wanting to work with them, not thinking that discrimination against them was of any importance. And many of them, if not a majority, advocated against funding to help people with addictions and mental health. I treat a lot of nurses who have addictive disorders, and they inevitably end up under contract with either the Nurses Health Program or the College of Nurses of Ontario. And if they're lucky enough to have a job to go back to, then they can go back to that job. But if they're unlucky and they're between jobs when they end up on that contract, their chances of finding employment are almost nil. And I have several nurses who've gone through this and applied to dozens, if not hundreds of jobs. And some of them have been told quite explicitly, as soon as it comes out that they have an addiction, there's no way that they're going to get that job. You know, I think we have actually met once before. I just wanted to add that my dad probably had Asperger's, but no one really knew what that was at the time. He was a mathematician. He couldn't really read body language, and he wanted me to be just like him. You know, everything else was suspect. He was hostile to the idea of me having friends, and hostile to any friends I did develop. My mother, she was kind of swamped. She did what she could, but she was sort of in a stuck place herself. She didn't really know that two different people could have different emotional responses to the same event. And when I found this out when she was in her late 50s, I was kind of astonished, but it kind of made sense in another way. You know, both of them drank heavily and often regularly. Both of them smoked regularly and often quite heavily. And I stank of smoke when I would go to school. So let's look at stigma. I like to think of stigma as something I like to call ignorance in motion. So here's a thought experiment for you. Imagine if in medical school, if we were taught little to nothing about abdominal pain. We weren't taught abdominal anatomy, but we knew that we should do something surgical because that's important in abdominal pain. But we weren't really taught about diseases in the abdomen. We weren't really taught any anatomy, but we knew that when a patient presented with abdominal pain, we'd probably have to cut them open and do something. Well, if this absurd example was true, every time we saw someone in the emergency department or our offices or on the wards with abdominal pain, we would be likely to think, oh no, not another one of those patients. So unfortunately, in the systems that I'm aware of, education and knowledge is very much lacking around addictions, not only mental knowledge, but also sort of a heart knowledge. My supposition is that with these nurses who get rejected and discriminated against on the basis of health condition, that employers actually have no idea about the difference between a nurse who's in healthy recovery and has been sober for years versus a nurse in active addiction. They just see addiction and run away and push them away. And I am convinced that for every nurse who's in healthy recovery, who works in a hospital, there's at least as many, if not many times more, such professionals, healthcare providers, who are in active addiction at that time, but maybe it just hasn't got bad enough for them to be caught yet. Because in addiction medicine, what I've learned over time is that the job is the last thing to go. You know, come to think of it, I think we have met a couple of times. Let me tell you this. One of the weirdest things about my family was that my dad had this fervent belief that I was about to be an imminent failure if I didn't have the same independent intellectual interests, sounds fun, right, that he had when he was a child in Europe. And he would talk and obsess about my imminent failure in life because I didn't know what I was going to do for the rest of my life at age 14. And he also cited my total lack of accomplishment. This was at a time when I had the top average in my private school between grades 8 and 12. I was a polite kid. I was well mannered, and the friends I did have, their parents really kind of liked me. But I was not seen at home. I sort of felt disgusting and loathsome somehow. So, if we look at stigma, what we can see is that stigma is like a form of trauma reenactment. I am firmly convinced that every mental and emotional disorder, or almost everyone, the majority of them, arise out of ruptures in relationships between us and other people. And in the process of those ruptures, people have often experienced judgment and rejection. But if we as clinicians add our own judgment and rejection to these ill people, then our patients suffer the same thing that generated the conditions that they're presenting us with, and we're just adding to their pile. And I'd offer a thought to consider. What if our judgment and rejecting of others actually arises first out of our own self-judgment and self-rejection? Addiction can also be seen as an attachment disorder. So instead of being able to attach to other human beings successfully because they're either not available or someone lacks the skill, people get attached to drugs, to behaviors, to pathological patterns because they feel good, at least in the short term. And the casino or the beer bottle may be more available and a reliably good and available source of good feeling than the people around them when they needed them. So therefore, if we're unavailable to our patients, it kind of replicates the initial reasons that probably drove them, even from many years ago, to come and see us in the first place. You know, I think I do know you because we've spoken a few times now. So what happened was I disappeared into video games and I disappeared into fantasies, mostly fantasies about meeting a girl, talking to a girl, dating a girl, maybe having sex with a girl someday. And at least then in those fantasies, I felt good. You know, I was very committed to the fantasies because they consistently made me feel good, even though if I'm really honest about it, there were all these emotional hangovers after because it didn't really actually produce any viable relationships that way with any other people. So, I'd like you all to know that addiction is a solution to trauma, and there's only two reasons people use drugs, and including people who use drugs or processes that they overuse and get compulsive around. Number one, they feel bad, and number one, they feel good. And often people just don't know what else to do. So think of trauma. We could talk about what it is for days, but here's with one way. Trauma means that there's a pocket or there are pockets of emotion from our experiences that we just don't know what to do with. And they can come in all kinds of different sizes. And one thing that I found that was, through a conference that I was really surprised about is, do you know what the most common post-traumatic psychiatric disorder is, according to research done in Australia? It's actually depression. It's not post-traumatic stress disorder. It's depression. So there's actually more to the story. A few years later, I fell in love, like genuinely fell in love. And it didn't last long. It was just a few months long. But finally, someone saw me, like someone, I didn't have to pretend to be someone else. I didn't have to walk on eggshells all the time. And I just felt so liberated. Unfortunately, I couldn't stay faithful, maybe because of all that fantasy, and it ended. But she was willing to still stay friends. And I was really happy about that because I came up with a plan. And the plan was I would be such a good and non-demanding friend that she would fall in love with me again and that we'd be together again. And unfortunately, I became obsessed with this plan. I obsessed about what I would say to her next time I saw her. I obsessed about when that might be. I obsessed about how soon is too soon to call, or how long should I wait? And what did that mean the last time we saw each other? And would she like this thing if I bought her this gift? So then after 4 months of this obsession, which did kind of make me feel good, but also, as I said before, it didn't lead to a relationship, I realized I just couldn't do this anymore. It wasn't healthy, it wasn't working, and I need to just get on with my life. So on New Year's Eve, 1992, I decided enough of that fantasy, it's over. And that day, I started plunging headlong into depression. And soon enough, I wanted to die. So there's a couple concepts I want to leave you with that are very important. One is that in my experience of my patients and of our culture at large, there's often this confusion, in my opinion, between blame and responsibility because people think that they're the same thing. So many people see them as the same thing. So if you think of how people talk about it, about, someone who's responsible for this, who's to blame for this, it's like they're used interchangeably, but I don't think that they're the same. Because in my experience, blame has shame and judgment toward it, or within it, and it looks often backwards in time. And we can also point the finger at us in blame. It's all my fault, if not someone else's fault. Whereas responsibility has kind of more of a sense of empowerment or self-worth, and it looks more to the present and the future than blame does. Finally, I'll share you with a kind of paradoxical concept that my addiction medicine teacher shared with me years ago. And it sat with me for a long time. And here's how he explained it to me. Every moment is predetermined, but at the same time, at every moment, there's a possibility of free choice. So everything I've experienced before now leads to now and constrains the choices I can make now. But at any moment, I have the possibility to choose freely. And when people are sucked into compulsion, they lose that ability to choose freely. The core of addiction is a loss of control over amount of use. So the question is, can we see ourselves and our patients as processes in evolution as opposed to categories that stay static? Thich Nhat Hanh, a renowned Zen Buddhist teacher, teaches by lighting a candle. And he lights it and says, when conditions are sufficient, the candle is lit. And then he blows it out. And he says, when conditions are no longer sufficient, the candle goes out. So how can we either contribute or detract from the creation of sufficient conditions for our addicted patients and colleagues to get well and stay well? So let's return to our case study, the 21-year-old male with depression. So he was fortunate enough to find some short-term counseling with a psychiatrist through family connections. Over time, he was able to access a number of therapists and groups and teachings that enabled the mood disorder to stabilize. And eventually the addiction was also recognized and defined later and also stabilized with sufficient time and treatment. Despite all this, he was still able to get into medical school and through residency without any major issue. And he ended up choosing to focus his practice on the treatment of addiction, mental health, and trauma. And years later, he was even able to tell some of his story at an academic conference, which was kind of cool for him, actually. So there's a couple things I haven't told you yet. That emergency room physician, he was tired, and I could see it in him. He'd been working really hard. And luckily or not, I had had a lifetime of experience of taking care of the emotional needs of older adults at that point. And so he cared, but I I knew what he wanted to hear so that he didn't have to go through the trouble of admitting me to hospital. And to be honest, I didn't want to be admitted to hospital either. So I lied and I told him no, I wasn't feeling suicidal anymore. And he let me go home, which was kind of good. But here's the other thing. Before I ever saw him, I was waiting to be seen in the waiting room, and this Indigenous woman started talking to me. You know, she was probably in her 30s or 40s, but to me, she looked really old. And it seemed to me also that she kind of lived a heavy life, like she had some scars on her face and just looked like she'd been through a lot. And she said, "What are you doing here?" And I said, "You know, I don't know what I think or feel about anything. And I've convinced myself that that means I'm a nobody and I'm a nothing and that I don't exist." And she gave me this funny look and she said, "No, no, that's not true. You're a person. You are a person." And I tried to convince her that I was a nobody and a nothing. And she kept coming back to it as like a mantra. "No, no, you're a person. You are a person." And I didn't know it then, but that was a seed. Thank you.